So there are a bunch of options. The first option is time, right? When we look at some of these interventions that we're going to talk about, we always compare them to time. And studies always show that if you just waited long enough, the air leak will eventually stop. But that can be weeks. So we're not always able to do that just from a practical perspective. And it's certainly not helpful for a patient to be stuck to the wall or have a chest tube. And so some of the other things that we talk about, some are more evidence-based than others. I'll start by saying that. And I will just start to a couple of them. A little bit, it depends on what sort of the original reason for the pneumothorax was. And so if you're dealing with a post-operative air leak or post-operative persistent air leak or post-operative pneumothorax, sometimes the right thing to do is just talking to your surgical colleagues and say, hey, does this patient need to go back in and get either a staple or something to surgically repair that pleural defect? If there's a more proximal leak from a bronchopleural fistula, then that certainly needs operative intervention because those usually don't heal with conservative methods or sort of these minimally invasive techniques that we may talk about. One of the other things that we commonly think employ is something called a blood patch. And it's an autologous blood patch. And so we're using the patient's own blood in that scenario. Not a lot of evidence to support its use. The case series that have been reported so far have shown some success. And so it is relatively commonly used just because of how easy and safe it is to do. And so it's an autologous blood patch. So what we do is we literally take 100 to 120 cc's of the patient's own blood and then insert it via the chest tube into the pleural space. But the goal being that blood will hopefully find its way to this pleural defect and create a clot over it that will then, like patching a tire, just stop the leak from continuing. There's also some pleurodesis that happens because blood is a partial pleurodesing agent. And so you will get some pleurodesis as well, too, to get the lung to stick up to the chest wall. The benefit of a blood patch is that you don't have to have full apposition of the lung, meaning the lung doesn't need to be fully reinflated for it to work, right? Because even if the lung is partially down, that blood clot is able to miraculously form over that location where the hole is, then you're usually good. That's in contrast to other forms of pleurodesis. So other forms of pleurodesis with things like Talc or doxycycline or some of the other pleurodesing agents out there, they'll really only work if the lung is stuck up to the chest wall. If there's a significant difference or space between the pleural and visceral parietal surfaces, usually chemical pleurodesis with something like Talc is not going to work in those situations. So that's another reason to think about it. The biggest risk to a blood patch is infection. And it's basically like adding culture media to wherever you're putting it. And so if you have any concern that there's a pleural infection, you want to be very wary of putting in a blood patch because you will just propagate that infection to grow. And that's why we're also as careful as possible about doing this under as sterile technique. And so when we draw the blood off, we want to draw it off quickly under a sterile circumstance, ideally with a freshly placed central access point pick, and then quickly and as sterilely as possible insert that in the chest. The other options are endobronchial valves, which is something that's really come a long way in the last 5 to 10 years as a wonderful tool for patients with persistent air leaks. And so these are one-way valves, so and they're placed bronchoscopically. And so they allow, in whatever segment you place them, they allow air to move proximally. So for air to come from the lungs to the central airways and breathed out, but they don't let any further air go out into that segment. You can imagine if you have an air leak coming from the right upper lobe, if we place valves in the right upper lobe, you won't get any more air going into the right upper lobe, and therefore the air leak will resolve. And so what we do in those cases, those procedures are done bronchoscopically, as I said, under anesthesia. So we put an endotracheal tube in, go in with the bronchoscope, and then try to figure out where the leak is coming from and try to place the valves there. So what that usually means is studying the CAT scan pretty carefully to get some clues as to where the leak is coming from, especially patients with really bad emphysema. Sometimes there's just a bleb or a bulla that's ruptured that you can easily see as having ruptured, and that gives you a good clue as to where you should go to put the valves. But sometimes that's not the case. Sometimes the lung is either so diseased that it's hard to know where it's coming from or not diseased at all, and you just have to go in and sequentially figure that out. And so what we do is we sequentially occlude segments using a balloon on bronchoscopy. And what we're doing while we're occluding segments sequentially is we're keeping an eye on the pleurovac. And, in our example patients, we'll go down and obstruct the right lower lobe in that patient, and we won't see the bubbling change at all. If anything, the bubbling might get worse because we're actually seeing more air out going across that right upper lobe. Whereas take the balloon down and obstruct the right upper lobe, the ideal setting is that we then see complete cessation of the air leak. And that tells us, okay, the leak is being supplied by the right upper lobe, and we'll go ahead and place valves up there to hopefully move the patient along there. That's the ideal setting. To be honest with you, in clinical practice, it's a little harder. Oftentimes these patients have multiple leaks or collateral ventilation such that you don't really get that clear demarcation of obstructing a segment and getting the leak to come up. So in those settings, you're sometimes looking for where the leak improves and trying to slow down the leak as much as possible to, again, help the patient get off suction and move toward water seal. Those are the most common things that we do in patients with these persistent air leaks. Surgery is something that we do oftentimes think about in the right patient population, but they're not surgical candidates, then blood patches or endobronchial valves and time are the three big mainstays of their care.
Circling back, do you speak a little bit to when are patients ready for clamp trialing? How do you think about benchmarks after they've been clamped as far as when they're ready for tubal and that final stage and progression before they're ready to move on?
Interesting. If you ask a couple of us, we may have different answers to that question. But personally, I like to be more conservative. And, I like to wait until the air leak is really completely resolved before removing the chest tube. Some people argue that there's this concept of a drainage dependent versus a drainage independent air leak, that by virtue of having the tube in there, you're actually propagating the air leak. And that's particularly true in patients who have a trapped lung, where, if you try to pull that lung up with a chest tube, you're just propagating the air. And so in those cases, sometimes people argue for pulling the chest tube or clamping a chest tube even when there is a small air leak. I'm on the more conservative side of things. So I really do want to see the air leak completely resolved before I think about doing that. And so once the air leak has resolved, then you can go ahead and thinking about clamping them. And so clamping them just means using whatever sort of method to clamp the chest tube you have in your particular chest tube. So for most of our pigtails, that's again that three-way stopcock where you turn the three-way stopcock off towards the patient. The other way to clamp a chest tube is, of course, just to put a Kelly across the tubing that goes from the chest tube to the pleuroback. And the important thing about a clamp tube is it's basically not having a chest tube at all. And so you really want to be mindful of monitoring that patient and communicating with everybody about what you've done, including the patient. And sometimes patients can be their best advocates. And so when I'm clamping a chest tube, I will show them. I'll say, hey, this is me clamping your chest tube. If you start having chest pain, if you start having shortness of breath, if you don't feel good, call for help and unclamp your chest tube. And this is how you unclamp it. And in most patients, they're able to be empowered to do that on their own, but certainly communicating that with the nurse and the floor team is really critical as well, too. And so generally, we do clamp trials for about 4 to 6 hours, where sort of clamp the chest tube and reassess the patient after 4 to 6 hours, the chest x-ray, and just an assessment of how the patients are feeling. In some situations, we may want to clamp longer than that, especially if a patient had an air leak for a while and you just want to be 100% sure. You can't clamp for longer to be 100% sure. I get worried about the overnight clamp trials just because, again, you worry that with turnover of nursing, of teams, that the communication can be lost. And then you worry that a patient's going to have a bad outcome when whoever was taking care of them didn't have the knowledge that they're clamped. And so, again, speaks to the importance of really documenting and communicating it really well with these patients. I've had a bunch of these situations where the patients have been without an air leak for like days. So like we'll go in there and literally have them cough up a lung, and you won't see a single bubble. And so we feel really comfortable and we'll clamp them. And then for whatever reason, and I've never really fully understood the physiology behind it, but then the lung will start to collapse and then you'll unclamp the chest tube and you'll see a couple of bubbles come in. So sometimes I think these are just like tiny little hidden air leaks that you just can't appreciate with the pleuroback, but they do build up over time. And so you really want to go through that step of the clamp and then repeat the x-ray to see how the lung is looking before pulling the chest tube. But once you have that successful clamp trial where you've done that 4 to 6 hour test, or overnight, depending on the situation, the lung looks up, patient feels well, then you can go ahead and remove the chest tube. And then the practice of removing a chest tube is pretty easy. You want the patient, you want to warn the patient that it's going to hurt because these inevitably hurt on the way out. But usually by this time, there's been a little bit of pleural inflammation that's been developing. because of the virtue of the chest tube itself being in place and irritating the pleural surfaces, as well as whatever other things that we've thrown into the pleural space to help move this process along. So the pleura can be quite irritated, and the process of removing the chest tube really does irritate that already angry pleural surface even more. So prepare the patient for that process. And then we want the patient to be humming as they're doing on the way out. And so once the chest tube comes out, as the chest tube is coming out, have them hum or exhale, and then hold occlusive pressure on the tube as well, on the chest wall, as soon as the chest tube has come out, to allow no more air to go back in. And then, people ask a lot about the post-pulled chest x-ray, and I shy away from that because, I don't know, not that I don't want to know what it's going to show, but it usually doesn't change what we're going to do. And it oftentimes just causes a lot of sort of agita about, is the lung up, so we need to put the chest tube back in, and then tend to shy away from doing that.